Okay, good evening to one and all. My name is Theng Lam. I'm the Executive Director of the NTU Local Community Engagement Office. First of all, let me apologize for the slight delay. As some of you may know, the delivery truck, actually the tire burst on the highway. So it took them quite a while. Actually, they did rush. And they are supposed to set up everything by 6:30, and they reached at 6:30, so they're about maybe 15-20 minutes late. And because of that, I think your dinner is a bit late. So yes, please accept our apologies. Now, for those of you who are visiting NTU for the first time, welcome, and welcome to one of the top 15 most beautiful campuses in the world. In Asia, there are only two. One is Peking University in China, and one is NTU right here. Do you know that before? No idea, right? So I'm telling you this. Okay. Thank you. Now, today's program has got a few segments. We will have the keynote speaker, and after a speech, we will have a panel discussion followed by Q&A. So if you have any questions for the speaker, just hang on to it, and you can actually ask her during the Q&A session. NTU, now most of the universities in the world have got three major objectives: education, research, and social responsibility. Now NTU has done very well recently, especially in education and research. As some of you might have read it from the newspaper, we are currently ranked number 11th in the world in QS World University Rankings, and number 1 in Asia, which also means we are number 1 in Singapore. Well, we have done quite a fair bit also in terms of social responsibility, but we want to do more. So one of the many initiatives that we have is to organize this type of digital monthly talk series. So it's held once a month. We actually invite various professors from NTU to speak on their areas of expertise. And in so doing, we hope that Singaporeans will be able to appreciate research as well as its benefits. So we are doing this on a monthly basis, and the fact that you are here, you are in our mailing list, so we actually invite you, send out the notice once the next talk is up. Okay, so just a quick tell that the next talk will be on the 25th of January. All right, and we have a professor from a business school talk about a very interesting topic, which I will just hang on to it first. Huh? Okay, this evening we are very honored to have invited Professor Leng to talk about Uberising health coaching, an answer to just-in-time, bite-sized, and affordable eldercare. Now, Prof. Theng is Professor acting as a Director at the Aging Research Institute for Society and Education, NTU, and Interim Director, Nanyang, NTU WSH Institute Research Center, and Director of the Center of Healthy and Sustainable Cities at the Wee Kim Wee School of Communication and Information. With recent focus on interactive systems and devices for healthcare and education, her main research interest is to develop innovative ways to assist in the design and evaluation of interactive systems and devices, making research relevant and impacting society. Now, without further ado, let's put our hands together to welcome Professor Theng.
Good evening to all of you, and we would like to thank you for taking time to come on a Thursday evening. and very, very close to even Christmas. In fact, I think amongst ourselves, we were thinking like, how many of you will turn up? We thought that we might be speaking only to a handful. But we are so pleased that, you're able to come. Please pat someone on the right-hand side or left-hand side to say, well done. Thank you for coming. So, it's like myself, I will actually introduce myself, with this slide, very wordy, but I would like to actually put into context the way that I look at health coaching. Right? So, it's like my background is in experimental human-computer interaction, doing a lot of work on, digital libraries, hypertext, and in recent years is on elderly and technology and health. Yeah, my focus is very much on looking at user experiences, innovation in terms of tools, techniques, methods, models, and also to understand people, their information needs, and how they use technology. So that's how I will be actually positioning the presentation. So this is how the presentation will, will be like. I'll start off by talking about aging. The landscape in Singapore, and and I'll be actually also giving a very quick overview of ARISE. Now, ARISE is the Aging Research Institute for Society and Education in NTU. We have set up ARISE. And I'll talk a little bit more about ARISE in terms of our programs and projects. And then specifically to look into, Uberised health coaching. What does that really mean? And then, to also highlight 3 projects which I want to bring to attention, some of the things, which is really about people, right? And when we talk about technology, it is important for us to also not look at people, but what are the factors that will make people want to accept and adopt. Then after that, I will, look at some of the reflection points so that we can actually think about it. We are working in this area, but I wouldn't say that we are experts. In fact, with engagement like this is very, very important to actually help university. You are the people that we want to actually design the system. So, so we encourage you to engage with us as we discuss. And later on, we have the panel discussion, and that's where there'll be more questions, more discussion points. Okay? Now, so the aging landscape. Okay, if we were to actually look at this diagram, right, it says that by 2030, 1 in 5 Singapore residents will be 65 years old and above. Now, we have been using this graph for many of our presentations. However, we forgot that this is only a projection. Right? In fact, the current, percentage of, people in Singapore who are 65 years old and above is already 13%. Right? Now, that is actually, worrying. Reason is because we are projecting it at, 13.5% in 2020, but we are already hitting 13%, which means that Singapore is aging faster than projected. Right? So what does that mean in terms of, social and economic cost? It would mean that when they actually look at, the number of people who are in the working age band of 20 to 64, by the year 2030, there will be only 2 persons supporting 1 person 65 years and above. Right? Currently, it is about 4.7. Okay, so this is 2012 is 5.9 person to support 1 elderly person. Right? So Singapore population, so if you look at Singapore citizens and permanent residents, this blue one shows Singapore residents. And the number of people who are 65 years and above is 13%. But if you look just at Singapore citizens, it is actually 14.4% at in 2017. So we are aging faster, And it's like the total healthcare cost by 2030 could be this amount, which is actually a lot of cost, right? And the government is actually looking at ways in which to make it more cost effective. Right, this is another graph that shows that, it's like amongst the rich income countries, Singapore is actually aging even faster. It's like in terms of the, it's like percentage of change in population, 60 years and above, is even faster than Korea, Japan, and so on. Right? So let me just, it's like this. So this is a situation in Singapore. Is it, it's like, is it bleak? No. I think we can celebrate, it's like old age, right? How do we celebrate it? We can actually celebrate it by looking at, like the positive aspects in terms of aging. And if we were to age gracefully, we age productively, like that could actually, like be something, like that we should work towards. So this is actually where I want to introduce, like ARISE, which is NTU Aging Research Institute for Society and Education. And this was, in fact, the idea was actually, like conceptualized 2 years ago by, like the NTU President Bertil Anderson. He said that, like Singapore is aging very quickly, like let's look at NTU. What is it that we are, like doing in terms of aging research? So he asked us to write a white paper to see what is it that we can actually do. So in the white paper 2 years ago, we were thinking that, yes, if we were to actually address the aging issues in Singapore, it's like, what then is our vision? This is our vision, to empower the aging community and improve the quality of life, right? And the mission is to enable the healthy, active, and independent individuals, like yourself and myself, right? How is it that we can actually live meaningful social integration and productivity? And because NTU is a technological university, we have many of our researchers and colleagues looking at technologies, and that's not enough. We also want to make sure that we understand, like aging related psychosocial issues, right? So in our white paper, we actually say that, like there are faculty who are doing research in 4 areas, broadly 4 areas, aging medicine, social integration and education. Okay, I cannot see. This is aging in place, and then you have lifestyle care and lifestyle enhancement. So I'm going to actually play a video, right? I hope this works, because just now we were testing. Yes. Yeah. This is research at NTU on aging as well as health.
I'm calling for help now. Ambulance is on the way.
So this gives us a very quick overview of the kind of research that we do in NTU. But let me show you in several slides. So we have, like 4 trust areas. First trust, aging medicine. Second trust, social integration and education. Third, aging in place. Fourth, care and lifestyle enhancement. We have made it, like our focus to actually look at the outcomes. So in other words, if we actually do research in this area, basically what we want to see is to promote physical well-being through prevention, delay onset of disease. Right? And what we want to actually, like look into is the aspect of healthy aging. Right? Now, for social integration and education, right? We were discussing, it's like if we were to actually look at, it's like aging issues, it is also important for us not to just provide solutions, it's like to actually help in terms of healthcare, but what about, it's like looking at aging, it's like, and, so look at the different aspects of aging gracefully, aging engaged, aging productively. It's like, what does that really mean? It's like to maintain and enhance social integration, participation, and productivity of aging community. The third thrust is aging in place, and that is actually, it's like allowing individuals to be active and independent, and to provide friendly and safe environments so that you will encourage independent living. And the last one is quality aging. We also want to live long, we want to live well, right? So what can we do? It's like we want to look at research to help to maintain and improve quality of life through care intervention and innovation in technology, right? So there are many more areas that we are looking in all these different trusts, right? And it's like, why Arise? Arise is timely because Singapore is aging rapidly. And it's also important because the government has put aside 200 million over the, over 7 years for research to be done so that, it will be actually useful for Singapore. And in terms of NTU, we have a strong in multidisciplinary research capabilities that cuts across science, engineering, medicine, business, like design, as well as behavior and social sciences. Currently, at the count of, October 2017, we have about 100 over people across the different colleges and institutes, right? When it comes to research, it is not only just research. We also want to look into education, but most importantly, this is actually where university, we are striving to do even better. It is actually translation and implementation. Now, meaning that we want to actually use the technologies in communities to show that it is actually useful, right? So if we actually look at Arise is actually working, with all the different schools, colleges, and institutes, and we have signed, collaboration agreements with, Institute of Geriatrics and Active Aging at Tan Tock Seng Hospital. This is GERI, which is a National Institute on Aging and Research. Workplace Safety and Health Institute with the Ministry of Manpower to look at older workers, as well as the National Healthcare Group, which is really working very closely with NTU, the Lee Kong Chian School of Medicine. We are also working with other commercial partners, for example, like Apple, right? And Arise, currently I'm the acting ED, and we have 4 trust leads, reporting directly to the president, and then the steering committee consists of all the, the deans of the colleges. That means that NTU is putting in great emphasis to look at aging research. Right. So let me very quickly go into the strategic programs and projects. Right. So I mentioned about Arise. That is to empower the aging community, improve the quality of life. We have 4 trust areas here. These are our outcomes. And we want to measure, the success of the research and the programs, through some of these outcomes, right? And this is our roadmap where we actually talk about, strategic, programs. And if we are looking at an aging population, what we want to see will be, can we continue to encourage healthy and active aging and providing integrated elder care. Okay, so very quickly in aging population, we look at the challenges, right? Aging, there are associated with sarcopenia, disability amongst the elderly and so on, anxiety, experience loss of cognitive function, hearing, vision, it's like social and support networks, and that will affect the psychosocial wellness and well-being, right? Living conditions, can we make it better for the elderly? Can we actually encourage independent, like living? And also training and education. And this is actually where the focus of today's talk is, really on training and education. Do we have enough people to actually help, like older adults as they live, like better quality life, right? So if we were to look at, like issues, in fact, there are we have actually categorized them into 3 broad categories. One is really on biology of aging. This is actually part, like of the individual, where we actually talk about chronic diseases, right? Physical, mental well-being, nutrition, right? The second, like category looks into the social health, right? Family proximity, loneliness, education, right? And the third block, like looks at work and retirement, healthcare costs, income and assets, right? Now, if we were to look at the healthy individuals, it's like in research, when we actually talk about health, it's like research, we actually look at different types of health research stages, right? So we could be looking at promotive health. That means I can encourage people to stay healthy. I can also encourage people to prevent diseases, stay healthy. So for this 2 aspects, this is actually a lot more, before someone falls sick, try to keep the person healthy. Now, if someone has actually fallen sick, then it will be actually looking into the curative aspect, how to get a person well, right? And the same thing with, like rehabilitation. Some, like the functions have been, like injured, and how do you actually make a person function better? And lastly is palliative, which is end-of-life care, right? So for Arise, we are focusing very much on this, because this forms about 80% of the, like of the population in terms of, like the older adults. If they are healthy, keep them healthy, right? How do we do that, right? So over here, we look at 3 aspects of health. That is on the personal health, community health, and workplace health, right? So if I want to actually keep, like the majority of the population healthy, then, like we need to actually understand these 3 different aspects and the interface of these 3 different aspects, which we call it cross-cutting, inter-trust, multidisciplinary strategic initiatives. What does that mean? Like what we want to see will be, like could we come up with programs, research that will help, like to look at outcome changes. For example, like mindset, behavior, sociability, lifestyle, policy, and so on, right? So what we have done at Arise is that, it's like we look at this one, Trust 1, 2, 3, 4. We also look at MOH initiatives. MOH is very active, so it's putting a lot of resources in actually helping, like to look at research to address aging issues and also health-related issues. And these are some of, like the MOH initiatives. Now, what we have done is that we have, Arise has actually come up with 8 strategic programs, and these are the 8 strategic programs that we want to map to our trust as well as the MOH initiatives. So for today, I'm actually talking specifically about strategic program 5, which is Uberised health coaching. There are the other 7, like they are under the different areas that we map into national initiative, and that's important. We do research, we look at issues, but at the same time, we also want to align with national initiatives, right? So that it will be actually useful and helpful for, like Singapore. Right. So this is actually where, so I will talk about the strategic program number 5, which is Uberising health coaching. Right? I've shown this before, so what it actually says here is decreasing old age support. The ratio now is 4.7 and is expected to drop from 2.2 to 2.1. Yeah, and so what are the challenges faced? Not only just in Singapore but across the world, right? Cardiovascular disease. This is a major disease, and it accounts for 20% of total deaths in Singapore and 31% worldwide, right? And Singapore suffers, CVD at an average age of 61 years, right? Which is actually 10 years earlier than the Americans and the Europeans. Why is it so? Is it because of our lifestyle? Is it because of our stress? Is it because of the weather? And so on. Yeah. Then when you actually look at mortality, deaths due to chronic diseases, Singapore is even higher than global, percentage. Okay. Now, what are some of the challenges? I think all of us, could, kind of agree with some of these, areas. Things like job pressures, migration, smaller families, women in workforce, higher educational levels, low fertility rates. And this actually leads to substantial reduction in the number of available family caregivers. So what does that really mean? It would mean that, for 4 older adults in a family, you could actually have fewer people to look after them. Okay? Now, so there is an overburden on healthcare professionals. And in fact, in the papers, at Straits Times, October 2016, it actually says that, there's an urgent need of 30,000 healthcare professionals to take care of the increased number of older adults by 2020, right? So again, there's a need for, caregivers for older adults. High dependence on healthcare professionals, and we have doctors here, who will be able to say what are the situations in hospitals, and also when we actually talk about technological solutions. In fact, I think we are doing, many research projects looking at, IT solutions, but are they really fully tested and used in the community? Maybe not. And that's where, engagement with the community is very important for us. We really appreciate, working with communities to be able to refine the solutions that we provide. Okay. Yeah. So coming back to this concept of health coaching, this is an emergent concept. It's not new. It's actually been, mentioned in other places, in the world, in Europe, in America, and it actually originated from motivational interviewing. How to enhance patient self and management of chronic conditions and so on. So in the definition, it actually says that health coaches are professionals that can come from diverse backgrounds and education. They can actually work with individuals, groups, and the important thing is in a client-centered process to facilitate, to empower the client to achieve self-determined goals related to health and wellness. Right? And what does successful health coaching, look like? It takes place when coaches apply clearly defined knowledge and skills so that the clients can mobilize internal strengths and external resources for sustainable change. Right? So in summary, right, if we were to actually look at health coaching, in fact, there are people, there are papers published, and to actually refer health coaching to assisting patients to gain knowledge, skills, tools, and confidence, right? And the whole idea to be active participants in their own care in order to reach self-identified goals, right? And what are these? Right? To assist primary care physicians to meet the needs of patients, to increase patient understanding of physician instructions, to increase patient participation in shared decision making, to increase rates of medication adherence and lifestyle changes, right? So these are some of, the identified goals, right? And when we actually look at papers that have been published, compared to, like patients who did not receive health coaching. For this paper, which looks at the systematic review, which is actually the review of many papers, right? And it actually says that, like it is quite positive, right? In this case, it's actually about better weight management, increased physical activity, improve physical and mental health status, improve social life. So basically, if someone were to receive health coaching, like there seems to be an improvement in terms of, like mindset, behavioral change, and also physical and social health, right? This paper talks about chronic disease management. In fact, so it says that it is also an improvement to medication adherence, higher exercise frequency, reduced stress, right? Then the third set, so this category here says that, so it doesn't show no effects, right? Some studies show that there's no outcome, right? So health outcome, no change at all. And perhaps it is actually due to this unstandardized curricula for training health coaches. Whether so there is actually proper measurement in terms of effectiveness of health coaching, delivery mode, and also technological solutions. So in other words, like when we actually read the literature of like papers written on health coaching, there are papers who say yes, health coaches are good. Like, but there are some papers who say maybe not. Like, then what are some of the hindrances to making it successful? And it is here that we want to actually look into health coaching. Why? Because Singapore doesn't have enough caregivers. It's like, so what else can we do? We don't want to sit here and say, okay, it's like we don't have enough caregivers, then, it's like, and then we let, it's like nature run its course. But we want to see what we can actually do in terms of research, in terms of engagement with community and with healthcare professionals. Shortage of caregivers in Singapore, and this shown to be effective in some papers. So what we want to see is how do we address the increasing demand of caregiving services for older adults? Now, I use the term Uberize because we are into Uber services. So I don't know how many of you actually take Uber. It's like, and what does that really mean? It's like it means that it's like there will be actually, it's like supply demand. It could be actually low cost, it's like, and also just in time, it's like kind of solution. So, it's like, so I'm actually proposing that we look at an ecosystem to Uberize health coaching, and whether this could be a complementary alternative to caregiving services via healthcare professionals. And in this case, in this project, we're going to use diabetes as a case example. Reason is because it's like diabetes is actually one of the major problems amongst older adults, and also diabetes it's like it's like is an underlying causes for many of these chronic conditions. Okay, now if we were to look at chronic conditions which actually many older adults it's like face, it's not just one condition, but it could be a multiple of these conditions. There are some things that we can change. There are some things we can't, right? We can't change our family. We can't change our names. Like we can't change our age, right? So these are things that we cannot change. But there are some things we can change, and this is what we call modifiable variables, right? Things like this we can change in terms of lifestyle choices. It's like in terms of it's like whether we want to eat healthily or unhealthily. It's like do we exercise or not exercise, and so on. So there are certain things we can change, we change. There are certain things we can't change. We will have to actually see how best we can actually change the modifiable variables so that it's like we could still stay healthy and active, right? Now, so this is like our proposal. We are still working in this project. In fact, just about to start. But the whole idea is to propose a prototype, which we call Uber Coaches for Health Services and Knowledge, right? So if you actually see this as a prototype, what it wants to, it can do is to interface with mobile devices. It will also interface with a web portal, right? So let me just bring us through the workflow. right? So first, like you could have a physician to prescribe coaching task, like, and will assign it to the coach. The coach will receive the task and then do the coaching, right? Now, in our current, later I'm going to show you one of the current projects, and one of the challenges we face is that, yes, I can actually, it's like, have more people to provide, it's like Uber services, but are they trained? Right? It's like we have our drivers, it's like you want them to drive safely. We want our Uber drivers to drive safely, right? When we talk about Uberized health coaches, do we want anyone to take up, it's like health coaching? No, right? So this is actually where, it's like it's important to also look into curriculum design certification, which we are actually working, it's like with the hospitals and also, it's like NTU academic units. Whether there will be some certification of the authority and other things. You could also have like administrator to keep track of the type of health coaches that we have, it's like the ratings that they receive and so on. And we have a whole group of people, it's like working in this project, right? Now, this is also another example of how health coaching workflow could look like. So I could start with an initial coaching session. Patients with diabetes meet with the physician, and then like we can actually decide whether it is good, like for health coaches. If yes, then you continue to cover, like, and then like you have the physician's goals and the patients, you review it, and then you can actually have the health coach to explain what health coaching to the patient, and so on. If the patient agrees with future, like session with the health coach, yes, we continue, schedule it, and then the health coach will follow up, so that, it's like this person will be continually taken care of by the health coach. Now, if it doesn't, then halfway through, it's like they may want to stop the service. Okay, so the empowerment will be passed to the individual, and it is with discussion with the health coach, right? So that's our idea of how, it's like we could actually include the health coach with the older adults to actually look and, it's like into their condition, manage and monitor them, right? Now, what are the advantages? If you think in terms of advantages, it's like in terms of health coaches, it's like it's increased understanding of knowledge, emotional information and logistical guidance. It's like a lot of times, it's like we may not be, it's like the patients or the older person may not be aware of it. And the other one is also improve confidence in the decision making and ability to play an active role, right? More effective communication, improve coping skills, improve compliance with treatment, improve integration of services, right? So I've given a very quick overview of, like health coaching and the project that we are engaging in, right? Now, can we do it alone in terms of research? No, right? We can't. Okay, so it's like A is that we are talking about academic and professional training, right? So in NTU, we have just launched the Masters in Applied Genetology, and that's formal training, right? We could, so we are working actively with, like the program directors to look at how could we introduce modules such that if we train, like our students, they are more aware of, like older adults and aging issues. The other one is, like in terms of research, we have our interdisciplinary graduate school doing PhDs, like doing research and beginning to actually look at issues that may not be explored, but we want to actually continue to look into that, like, and come up with, like breakthroughs in terms of research in this area. And the third one is our Lee Kong Chen School of Medicine. right? So we have our medical students. They will be our doctors. They should be also introduced to many of these, issues and be aware of how to look after older adults. And the last one is where, starting to talk with Prof. Theng, who is a director, is actually the College of Professional Continuing Education under Skills Future. Is it possible that we actually rolled out more healthcare courses so that the general public, healthcare professionals, or people who want to take a second career change, right? They could also be, they can come for courses, learn about these courses. And for many of us who may just want to actually have some understanding of how to look after ourselves, how to look after our, family members. So we are actually approaching it from the different, aspects, so that as a university, we want to actually play our part in terms of not just only doing research, but also providing education and training. Right? Now, I'm going to actually, why am I actually embarking on this project? This Uberised, health coaching actually came about because I have been working on several healthcare projects. And this is what research, what we do in research. We actually work on several projects, and then after that we come up with new ideas. And these new ideas, they did not come out of the blue, but they actually came out of some of the earlier projects that we have been working on. So I'm going to actually talk about these 3 projects, but specifically to highlight this aspect, which is actually quite difficult. It's actually saying that if I want to actually roll out a program, I roll out, technologies, it can actually look good, but does it actually, will people accept it? Will people want to adopt it? And there are important issues for us to understand. So I'm going to actually talk into 3 different projects. In fact, this is a current project that I'm working on. It's funded by the Ministry of Health under the National Innovation Challenge on Aging. Right. And this one is the first one, which is actually the QP box. This is actually the where we actually look at medication adherence. And in medication adherence, we see that the elderly, they are not taking medication. So in this project, we actually developed this QP box, which is actually a pill box, interactive pill box. And it's also a timely reminder system, right? What we want to actually look into is actually not just telling the elderly to take medication, right? But it is also through timely reminders as well as social support. So in our project, we actually look at 2 aspects. One is the technology, the tablet. This one is a system. This is a physical interactive pill box. Okay. Now, when we actually look at the system, right, we actually tried it out. It actually may or may not work so well. Reason is because when we actually look at the framework, I can actually be doing alert, right? But what is important is that I have a lot of medical pill boxes out there in the market. Our medication adherence, rate is still 50% across the world, right, in terms of taking medication. What then is the problem? In fact, a lot of solutions have not looked into other aspects other than, sending an alert, right? Things like this, care support, right, education, is actually important in terms of, helping individuals to take medication. In fact, when we went to some of the senior homes, we worked with, agency for integrated care. They said that, some of the older adults just refuse to take medication. To them it's like, I don't want to take medication, and there have been cases of people running away from, caregivers actually giving medication. Okay, now the second one is, this is actually the project where we look into modeling and optimizing home care and caregiving services for the elderly. This is where it's actually funded by MOH, right? So in this project, we look at 5 services, and one of them is medication adherence, but we also look at smart home monitoring, rehab therapy, medication planning, scheduling, delivery, meal planning, general healthcare visits, right? And also some of like the data for both the patients as well as the caregivers. So I'm going to play a video clip, and I want us to actually just give you an overview of what this project and the final prototype will look like.
The Hokomo system is a one-stop integrated optimization solution for home care service providers in Singapore. To improve the productivity of home care operations, 5 key services were targeted for optimization. For the General Health Check service, the CareHi app facilitates caregivers in conducting efficient health checkup and health data collection. General health data such as weight, blood pressure, and glucose levels are recorded using CareHi. The accumulated data is then transferred to a centralized database, where it is safely stored. The meal planning and delivery component is realized by the Plannis app. Staff and volunteers assigned to elderly clients are able to check their client's profile, with the app generating meal schedules and informing caregivers of any special dietary needs clients might have. When it is time for delivery, volunteers and caregivers are provided with the most optimized delivery route based on client proximity. The medication delivery and adherence component ensures optimal routing for medication delivery, computing the best possible routes and schedules, and allowing caregivers easy access to client data. Moreover, integration of the QP Box medication reminder system facilitates the planning, arrangement, and bookkeeping of client data. The rehab therapy component introduces exergames and exercise regimes for clients. Through the virtual exercise therapist system employing Microsoft Kinect sensor, home care staff and volunteers are able to support elderly clients in starting and maintaining an exercise regime. The onboard fitness analytics module allows for the physical performance and health conditions of clients to be tracked. The system boasts a myriad of motion-based gameplay to keep elderly clients healthy, happy, and motivated. The emergency response component utilizes smart home monitoring technologies to set up an intelligent assisted living ecosystem. Through the use of passive and unobtrusive sensor-based technologies, clients' daily living habits such as movement, light, temperature, and home power consumption can be observed. In the case of unusual occurrences, alerts can be sent to clients' family members, caregivers, or home care centers. The assessment and report module integrates the information accrued from all standing technologies to generate up-to-date reports, facilitating the evolving commentary aimed to increase the productivity, quality, and capacity of home care service providers.
Okay, so in this project, right, I have actually chosen to show this because it's not, we actually use technology as a solution, but when we actually look at the technology itself, it is actually people that's very important. In fact, for this project, we work with 2 senior centers, like Chirti and Adventist, and the whole idea is to mobilize volunteers, right, to the network, but we are still running short of people. So it's just not enough people, for us to be able to actually mobilize, right? So, even if we have, technological solutions, you still need caregivers. And and it's important for us to have many more caregivers, but there are certain things that we can actually minimize. In other words, the manual, recording, that can be computerized, but the human touch still needs to be there. But what else can we actually do to make it easier for the caregiver, and also to provide more face-to-face kind of consultation with better quality. Right? Now, the third one, this is actually, it started off as a fun project. This was actually done about, funded by A-Star about 7 years ago. We were asked to actually look at elderly and technologies. So I say, elderly, can they actually use technologies? So that project is really looking at the factors affecting acceptance and adoption of elderly technologies. And in this project, we actually, I started looking at, the analytics, measuring all the movements, as well as we design a game. right? So this is what we measure. So I can actually measure, it's like your upper knee, lower knee, it's like movements and so on, right? However, after our study, it's like the senior centers that we were actually engaging in, right, they were actually not exercising, it's like they were only exercising when we were there for 6 weeks or 9 weeks. And then they were also participating because, it's like you have people to talk to, it's like you also have vouchers and so on. But we never got them to exercise beyond the 6 to 9 weeks. So we actually did this, it's like as a fun project because we said that, hey, why not we, think about other ways of engaging elderly. So we were looking at motivational strategies. And we said that if athletes were to, it's like exercise, like train for the Olympics for 4 years, right? Maybe the elderly can do something like that. So we actually organized a game. And in fact, 2016 was the first time we organized it. And, it's like just about 2 weeks ago, in fact, last month, we organized the second, game competition. And I would like to actually play this video clip because when we designed the technology, we wanted to design a game for the elderly to exercise. It helps, but the novelty drops after you play a few more times, right? It doesn't feel so exciting already. So we were thinking about some other means. Is it possible that we can actually bring in more factors, it's like social support, like in this case, it's actually, young people playing with, it's like someone older. It's like, will that actually make them, encourage them to actually exercise more? So this video clip shows the 2016 finals. And what we did was, we gave 1 month of training to the elderly, it's like to exercise. And we gave them, I think, it's like six games. They were practicing like crazy, right? It's like at the end of the first month, we actually organized competition in the senior homes, select the champion, right? So after selecting the champion, we think that champions will have motivation, right, to exercise. Those not selected, not motivated, isn't it? But it is not true. It's like so we have another 1 more month for the centers to prepare for the finals, right? And the finals was only just 1 day an event, right? So I'm going to show you the finals and be surprised that, it's like elderly, it's like we think that they cannot exercise using new technologies, but it's not true. 7 years ago, this would not be possible, but today it is possible. We only have 18 pairs of champions coming to the competition, but you see how many people came? 100 over.
很多人弄弄玩玩好了，开心了。
欢迎大家来到新加坡跨代全国游戏大赛。
But I hope that everybody feels a sense of pride and accomplishment for getting this far in the competition. So congratulations, do your best, and to all teams, good luck.
Team 1， 第一队 ，Please come to Station 5。首先呢，要玩 Fruit Ninja 2，就是要切水果。
第一次来参加，就很兴奋，因为跟我们做啦啦队。
那切那苹果很出力嘞，很酸嘞。
也可以增加我们的自制嘞，增加我们的身体健康。
手动啊的运动也很好。
It's healthy and it's a form of exercise also, mentally and physically.
对啊，我们要打气，打气，打得更大声，让他们可以做得更好，好不好？安迪爬了很久。
I can see that they really enjoy the games very well. I do see that some of them are able to use their hands more now. It's a good start, it's a good start.
All the elderlies are very competitive as well, so actually try to outdo each other as well.
I think the most important thing in today's is that not only do the elderly have fun, it's like the volunteers will have fun with them.
这个学生做得很好，对老人，因为老人不懂啊，他会帮你。
It's quite like first experience for me to actually play like Kinect with elderly. Yeah, it's quite a rare experience.
有拿到没有拿到，开心就好 ，happy 就好。明天我们来拿高这个金杯回家哦，啊，最好是这样。
Okay, so actually this one we really, I'm so grateful that the elderly were so supportive. But this year we did it again. We have several of the elderly who came back for the second competition. So in other words, although we started off as using technologies, but technology in itself is not sufficient. It is really about the people. And this is actually where I want to also emphasize, right? So some thoughts for reflection, because I'm looking at the time. When we actually have, so this is actually, really looking at, what Professor Sir George Porter said. There are two types of research: applied and not yet applied research. In the university, we actually do quite a bit of all this kind of research, not yet applied research. However, for it to actually create impact to community, it is important for us to continue to bring this into applied research, and we need the community to help us. You need to actually help us to sharpen, the kind of research that we actually do. Now, the second quote, in fact, this was an article from the Straits Times, and it is actually, saying that learning from Martin Luther about technology disruption. When we introduce, Uberising health coaching, we introduce technology enabled, solutions to support healthcare. It is not as simple as just coming up with technologies, but it is really, understanding, what is it that is, to help us understand the relationship with technology, how to amplify the best of nature, and also societies to have a subtler understanding of the interplay of identity. If I were to introduce technologies into the healthcare sector, is it actually changing, the identity of the patients, of the healthcare providers, of doctors, of nurses? Do we understand the power? Do we understand the technology? So in other words, it's actually important for us to look at what do, not only just designing technologies, but human-centric technologies. And the other thing is that as we actually, I spent several years looking at research on healthcare, and I realized that it is not a single solution. I can actually be designing a system, a prototype, but it is not sufficient. And I would like to actually throw in this concept of ecosystems. It is not just the researcher working, but it is a group of people who are actually working together, to understand the social, technological, and sustainable ecosystems. I show you the, the last project, we did it for, 6 weeks, 9 weeks, but the project did not sustain, but if you want it to be more sustainable, then you actually have to come up with other factors to understand the social, technological factors that will affect sustainable solutions. Okay, and just something that as I was preparing for another talk, we were actually looking at older adults. Some thoughts for to help us to think as we actually go into the panel discussion. If we actually look at personas, is basically a description of typical profiles of of older adults, and in this case, let's say we look at the current older adults, is 65 years and above. Many of them are not IT savvy, but they can be coached, they can be taught, like what I've actually shown in terms of playing Excel games. Okay, now there are also current workers. They are older workers. Some of them may not be so IT savvy. How could we actually help, like the older workers, right? Now, I could also have the modern older adults, and some of them are quite IT savvy. In fact, they, like they WhatsApp, like they can actually engage in, like on interactive, like devices and so on. There are also modern workers who are 40 years above, and they are very technological savvy. Okay, now fast forward, we talk about 2030. If we actually look at technological solutions, I'm preparing solutions for the current elderly, right? There are different profiles already, some more IT savvy, some less IT savvy. Now, fast forward the year 2030. Now, if I look at, it's like 13 years from now, it is actually the 52 years and older, which means that some of us qualify to stay in this category, it's like, and we are, it's like IT savvy, it's like, so in other words, for research, when we actually look at, it's like solutions, right, are we preparing for the current older adults, or are we preparing for the future older adults? Okay, now, and if we look at further future, 2060, 43 years from now, it is our 22 years and older. These people are highly, it's like a lot of them are IT savvy. So when we actually look into solutions for now, for the future, it's like we actually need to actually look in terms of who are we actually designing the systems for. Okay, and it's like, and I keep throwing in some questions here, like it's like, will eldercare health coaching be successful in Singapore? It has shown to be successful in some places in Europe. What then is the best approach to introduce health coaching to older adults in Singapore? What are the challenges with the acceptance and the adoption of health coaching strategy? It's like when it comes to Uber, right? It's like cars. Some of us are accepting it, some of us are still not. It's like, so how do we actually, it's like, encourage acceptance and adoption? What would be the impact of eldercare health coaching on the education, training, and of healthcare professionals in Singapore and in the region? There are some of these, like things that, like we could be thinking about. It is an attractive idea. It is a plausible solution. But there are also other things that we should also be taking care, and thinking about. Okay, so for Arise, as we answer those questions, we'll be answering the questions from the different perspectives, from research, from education and training, from industry and community engagement, from even national initiatives and collaborations. In fact, this one, like we are working very closely with the National Healthcare Group, also with Jerry. International collaborations. There is a big network outside Singapore, and like we have been invited to participate. And if this actually takes on, then we will have a lot more resources, like at our hand, and we could actually be a very good test bed for the rest of Asia. And lastly, it's really about healthcare models and policies. What are some of the policies that will actually work, or the models that work in Singapore? Okay, and I'm going to stop here. Right, thank you very much.
Thank you very much, Professor Theng. Can we give Prof. Theng another round of applause, please? The next segment is panel discussion. And first of all, may I invite our moderator, Professor Ting Seng Keong, who is the Dean of our College of Professional and Continuing Education, Prof. Theng. So he is the moderator. We also invite, of course, the speaker, Prof. Theng himself. Please take your seat. Dr. Ao Chi Chong, who is the CEO of Gong Wai Siu Hospital. Dr. Ao, and of course, Professor Nabil Zeri. He is the director of the Medical and Education Research and Scholarship Unit at our Lee Kong Chian School of Medicine. And the panel discussion topic for today is will eldercare health coaching be successful in Singapore? What would be the impact of health coaching on the education and training of healthcare professionals in Singapore and the region? I shall pass the floor to Professor Theng, please.
Hello. Good. Actually, we have originally with four panelists, 2 from private sector and 2 from the university. 1 fell sick. So now actually it's very heavy load on Dr. Ao here, okay, from private sector. I think very quickly, I think we've heard Prof. Theng. I just want to get Dr. Ao and Professor Lagu to just share very quickly, very short, on what they have come across in the field that they've been working on in relation to health coaching for the elderly.
Yeah, very good evening. First, I must declare a bit of conflict of interest and a bit of bias because for my hospital, we are actually partnering with National Healthcare Group to roll out health coaches service in our senior care center in the coming year. I think wearing the hat as a professional, as a doctor from clinical practice, the theory and concept of health coaching actually does have a very strong value proposition. The classical theory that I have learned through my clinical years, whether it's nurses or therapists, we are very used to health education and health promotion. So when you add the health coaching, you actually not only add the breadth, you add the depth. I think that is quite straightforward. But then when it comes down to the operational element, I think Professor is sharing, I think it's not so straightforward. In terms of literature review, when we use this word called health coach, most of the review are mainly overseas. And if you see some of the overseas, are usually where they have good outcomes, are usually very targeted, very focused. So for example, one that is very classical in America, what they do is what they call frequent flyers, going back to the hospitals at the A&E, and they have good health coaches, and they call them health coaches and work well. In Singapore, we didn't use that term. We actually do the same thing, but we call them case management. So again, terminology is very important. It's not as if something is so new that we know how. We use it as case management. Most of the time, our nurses train will do that. And again, we do have some quite good success on case management for frequent flyers in Singapore. Not too long ago, Ministry of Health also introduced the concept of health coach for taxi drivers. The media reported very good outcome, but I'm very skeptical because it's just like doing a health screening within 1 hour, they get good results. So I think it boils down to what she has mentioned at the end. A lot will come back onto the what we're talking about health coaching, what are we focusing on? And more importantly for the elderly, there are too many segments. And so I think as a general research question, I may then drill down to say that yes, there are some suggestions, but you talk about health coaching in a wide sweep, I think we have to be a bit cautious about. The final point, as a practitioner working with elderly, taking care of their care needs, there's only one philosophy I have. All these measures that we put in, they are not our typical evidence-based medicine, the type A type. You will always have elderly who will work well with this. You will always have elderly that doesn't work well with this. A classical example that my own experience is Gong Wai Siu Hospital is a very Cantonese approach. So we always do study trip. We go to Hong Kong and we found out that, oh, gardening is a very good thing to do. Of course, we know playing mahjong is also a very good thing to do. But we cannot sell mahjong in Singapore, but we can sell gardening. So we come back, we want to try. I was very skeptical. I don't want to waste too much resources, too much space. But yet at the same time, I don't want to say no. So we design a certain area tailored for the elderly, for wheelchair users and everything. I will tell you it's a total failure from the context of those clients that we work. The reason is very simple. We go to Hong Kong, we go to the valley, the temperature is 24 degrees. Of course, gardening is beautiful. In Singapore, the elderly don't want, they will stay in the senior care center aircon. So you have do gardening in the aircon, that means gardens by the bay. So what I'm trying to say is, do I say no? I think some like it, I will still keep it. So I think every new elements like this, I think we welcome it open arms. We will not say it doesn't work because the elderly really, they do like different things. Some may work, some may not work. But having said that, health coach will never be the evidence-based type A type where you have this bacteria, you take this antibiotic, it will work. It will not be. So I think we just have to accept that perspective. Please.
Okay, hi everyone. So my experience with the topic at different levels. So coaching as a concept is not new. I mean, you know, coaching in sports, coaching in everyday life. So I think we're discussing health. So I try to be very direct. I think this is an area that cannot develop only with academics or healthcare professionals. This is exactly the area where everyone is actually owning this development. So it cannot be, so that's why I think in order for this to further develop, you need to be on board, and a lot of you are probably already a health coach, or maybe you call it something different. But my experience with this is from training, of course. When you start to look at coaching, it's a personalized, personal support to everyone. And that's why we keep talking about sustainability and scale. If you want to offer a personalized or personal support to each of you, then it has to be personalized. It cannot be one size fits all, right? That's why this Uberising is very interesting. But then one takeaway from my research is you have to differentiate between personalized and personal. That's very important. You can personalize, and that's why I hear a lot in the research currently. It's still, we all decide what is the best possible outcome for you. So let's say for me, I'm 75. Personalized means we have this ideal state of being healthy, and then we have a coach that tries to put you there, right? It's helping you there. I'm more for personal. Personal means that this will never work unless you are convinced, you have decided what you want as a desired state, which is, it's not ideal, it's desired. Every one of you needs to put a desire. If it is in place, then the coach will be fully effective. So this is one thing. And I think the community is more experienced in this field because they know the people, they know what each of the people have a desire. We in the healthcare system, we are more optimized for ideal states. So we want health outcomes. We want healthy people at different stages. Of course, quality of life can differ. It can be stay healthy, remain as healthy as possible, up to, I think, end of life. It's also very important, the quality of, maybe not about disease, about, so that's the first research. And of course, then has an implication on how do we train doctors. I mean, at KC Medicine, we are very much family, community care oriented. But that has implication of what is the role of healthcare professionals, what is the role of the care, the society, the people around there. Another type of work on technology. NTU is big on technology, but then the technology research differs based on different schools. I think we are really strong on technology from all the different perspectives. The research I do is very much applied. So it's called design-based research. So it cannot happen without the context. I'm from Sweden originally. I believe that any research from outside, it's not really applicable until everything is contextual. So that's why I think adoption, all these terms are just telling something about how much of the context is coming into your research. If we are directional, it will never work. So the work I do is actually yeah. So we start from the beginning, already in the context. Of course, it's more difficult. I think whatever you do is already, there's no issue about adoption because it comes from the needs of the people. So that is the two I think I can start with, I can talk more about. Yeah, thanks.
Thank you. Before we talk some more, I think it's open to all of you, anyone of you who have any questions. Knowing our background, you can direct at us or you just fire a question and we'll sort it out. Any questions at all? There's uppermost in your mind. Yes.
Okay, my name is Leng. question to Professor Theng, who said that health coaching is adopted in many countries, especially European countries, and not very widespread, especially in Asia, for example. So, from your research, do you know the reason why it is some European countries are adopting and it is not being adopted in Asia? So this is one question. The other question is probably because you are in the academic field, and we know that many Scandinavian countries are very good in those parameters, health-related parameters, and all that stuff. What is the reason that they are so good and we are not so much? Yeah, that is my question.
Thank you. This is actually not. Yeah, this is better. Yeah. Thank you for your question. I visited, I visited Finland, I visited, Sweden, and the Netherlands. When it comes to the models of healthcare, they have also taken many years to come to the state where they are actually more successful. I think Nabil will be able to actually fill in more in terms of Sweden. One of the things that I observe is the kind of healthcare models that they provide. One is about cost, one is about the community support, and the other thing that they actually look into is when we actually observe is what Nabil has actually mentioned in terms of the personal. There's engagement with the community. If we were to look at health coaching, for example, they call it different terms, but actually when I use health coaching, I'm actually really thinking more about not only just the care providers, but also, individuals who may want to actually fulfill a certain role to help someone to look into care management of their own health. In fact, in the Netherlands, I've seen, coaches being, parked in, some of the, villages, remote places, and they have very little access to the, and very far away from the public health sector. So what happens is that they engage with this local, groups of individuals who actually work with, the community, and they know them. They actually know them very well, in terms of the residents staying in the community itself. In Singapore, I know that in hospitals, if you actually go to, the hospital, there are nurses and doctors who are very familiar with, with their patients. But in the general majority of us in Singapore, I don't go to the same private doctor. Which means that, when it comes to providing care and support, there is no, kind of, let's say, combined, medical records. So, it is actually very difficult for someone to actually follow up. So, coming back to the question of why, is it that we are not doing that well, it could be the way that we are structured. It could be the way that the healthcare, system, is actually structured. We are still working towards personalized or the, the combined, personal healthcare records, which I think the minister has just announced. That if we actually have this all combined, it could actually help to provide better healthcare, support to the individuals. Other things will be, technologies. In some of the European countries, using the mobile phones, using the tablets, engaging with, technologies is something that they can use. But in Singapore, when I came back about, 10-15 years ago, I wanted to actually design a healthcare portal for the older adults, and I couldn't because of the computer literacy level, the advocacy level. Today it is actually better, So in other words, there are certain other factors that we will want to actually look into, and that's where research comes in. To look at the factors that affect the acceptance of of certain technological solutions and interventions. A is efficacy, the skills of the individuals, and also the healthcare in terms of the models of care, also the support in terms of subsidies, the infrastructure. There are many other factors, and we are beginning to learn what are some of the factors that work and what are some of the factors that may not work. Like Dr. Al says that gardening is something that is successful in Hong Kong, but it is not in Singapore, and simply because of the weather. I just came back from Hong Kong, and when I walk into a cafe, I see many older adults, and in fact I think that Hong Kong has very two successful items which we can actually learn about. One is actually mahjong. Of course, it's not about gambling. The other one is yum cha, which is actually going to a cafe and people are just engaging and in communicating. I have gone to some of the senior activity centers. We have elderly who come down to the senior activity centers to engage, but there are many out there we are not able to reach, not even with research. And even in research, when we're actually engaging the elderly, they are the more active elderly. We have many of the older adults, in their homes, and we don't know how to reach out to them. And I think this is actually what Nabil has mentioned. It is not just the researchers, but even the community will actually help us to see how to reach out to the individuals staying in the home and with no family members, how do we engage them? We cannot even reach out to them. So in one of these projects, we are actually engaging with not only the healthcare provider, but also the community. We are actually working actively with the Southwest CDC, with community centers, because they could have more access to the people. Yes, we are still, we are still trying to understand the factors that, that will help to make it work for us.
Yeah, it's okay. Maybe I add just to explain. Partly because it's also the doctor's fault. I think because of our healthcare development over a short period, the knowledge, content, all have been residing on the doctors and the nurses' point of view. It's only gradually we are trying to share that say healthcare system is not about doctors and nurses. It's actually a multiple team. For a long time, therapists are only pegged at diploma level. Nurses are don't even allowed to take degree. It's only at diploma level. So I think, to be fair, our system has been very skewed towards, we call the doctors and the higher end, all the professionals, and they are like God, But we all train based on health education and health promotion. So the coaching part is definitely lacking. As a student, I don't remember any courses on coaching, but they will tell us how to do health education promotion. So I think it's also because of how we talk. But now I think gradually things are spreading out. It's not only that. Even within the doctor's field, there's also a pecking order. Everything we do is all determined by the specialists. Everything we do is determined by the acute hospitals. But now we're starting to say, hey, people like us in Kwong ICU, we should listen to them. We are serving the long-term care. Because we ourselves also have the data, we have the knowledge, we serve that. It's no longer the geriatrician or the rehab physician that will determine, but actually they also increasingly realize that actually every single one of us, including a volunteer, including a befriender, is actually part of this healthcare system. And all of us actually have a very important role to play. And gradually the role of doctor and the nurses, actually at the end should only become a plumber. There are other things that people are doing that are more important things. A surgeon is only going to take that thing. After that, actually, everybody else has to come in. It's just as the society hasn't evolved. So I actually am looking forward to more different types of healthcare professionals that actually stand at the forefront, but all with the same aim. That means for the best for the elderly. So I think we are taking that step. Even for me now, looking at long-term care, the acute hospital is actually talking to us. You know, like NTU, they wanted to invite me rather than just only Tan Tock Seng that comes here. So I think it's about recognition that all of us plays a role, not just academic, the professionals, and not just the professionals, but including many of you. In fact, I read latest literature review. In the States, they're looking at health coaches by the elderly themselves. So the competency required, but I'm very worried, I'm very scared is that our doctors are the one will say, hey, when you do this, are you doing the right thing, or whether you teach the wrong thing, you know. But I think this is something the journey we have to go through.
I think you said in relation to research. To be honest, there is not enough research in Singapore to claim that it's a unsuccessful model. You cannot say that. I've spent my whole life in Sweden, because these are two different models. So you end up there, it's fully funded by tax, so you pay high taxes, you pay almost 60% of your tax. Once everything is paid by the government inside Canada, then you can set up things nicely because everyone is paid, right? But I would say they are comparable, but we cannot claim anything unless we do proper research in Singapore. And once we do that, we discover there are strengths and weaknesses in each system. So the idea is not to adopt any kind of, is to actually empower the current. But to add to this, I think Singapore, the way it is now, it is a very nice place for disruption. Disruption in terms of we can be bold and we can actually advance very quickly because the challenges are nearby. I think industry has a play, private companies, volunteers, everyone has some. So we need to find this way of getting there. Like you said, for example, in Sweden, it's a different set of health professionals. There are physiotherapists, the whole flow is different. But there's no idea for us to adopt that model that was built up for 30 years. It's just a waste of time because we need to acknowledge there are also strengths here that does not exist. But I think technology is really open for disruption, which means that we have nothing to lose and actually we quick jump. It happened with other areas in Singapore. Once we're ready, you can actually leapfrog very quickly. That's why I was saying that the key now is to think about the foundation of this health coach. Is it, what type of health coach do we want? What are they supposed to do? Are they supposed to help people? Or are they supposed to support people to help themselves? Because if you need to choose direction, because then everything has to be aligned. The training, I strongly believe that everyone can be a health coach for different aspects. There is no need to actually train everyone for everything. So I think that's an answer to you. We cannot claim that it's unsuccessful in Singapore. The research is quite new.
To also add on, I think we talk about technologies, we talk about the models, right? There is one aspect that we also want to actually look into is actually mindset change, right? It is actually important, when we actually talk about someone wanting to stay healthy, to stay active, right? It is about the individual making a decision, a choice, right? I know that this food is good, is healthy for myself, but I may not choose to eat it. So I think in terms of engaging health coaches, right, it is also walking the journey and beginning to actually motivate, and making, certain, mindset change. And this is actually, this is something that, in many of the, the current models, we may have a very little contact with the individuals. So if you actually have health coaching, where the health coaches can actually walk the journey and keep on a regular basis, in terms of managing and monitoring the health of the individual, it may help. And the health coach may not be just a healthcare professional. It could be your family member, it could be a neighbor, it could be a friend. And if we actually think in terms of, if we have many more people who can be trained to actually provide, good advice for living, healthily and actively and encouraging one another, that could be also strategies, so, And I agree with Dr. Au. It's actually not just the it's like the doctors and the nurses, but it's everyone. It's like playing different parts, right, to help it's like each other to it's like stay healthy, stay active, and it's like and also having mindset change to say that I need to stay healthy and active because. What are some of the reasons? It could be because of my family members. It could be because of my children.
Not everybody is excited. Before I get another question, I just want to add something here to what Tao has said. See, in a sense, when we look at our system, we say there are flaws in it. Why? Because the doctors are very specialized. And specialization has got some negative impact. Because once you're specialized in something, you look at every problem from your specialization. Okay, and there are issues. So what we are trying to do here is to encourage health coaching. I think one way of thinking about it is we're trying to encourage each one of us to take the initiative. It's our problem. At the end of the day, we are going to be the elderly. It's our problem. Let's see how we can be at least prepared for that. Now, put ourselves as first aiders. Give ourselves that first aider training. So that if someone says something, at least I can think about it. I have enough background to think about it. That's what we are trying to provide. Okay, and let me just share an example so that you can see where I'm coming from. Just a few days ago, I was just having dinner with an old friend. He's 68, and he complained, he told me that he experienced giddiness. Right? So he was trying to figure out why was he giddy. So he got worried that maybe it's something wrong. So he went to a specialist. And what the specialist told him was, I think you need to go through MRI just to check through what exactly is happening. Alright, he checked through it, nothing wrong. Okay, then he said, maybe you get this disease spell because of your inner ear balancing problem. See another specialist. Again, they couldn't find anything wrong. So after he gone through all that, sat down and think about it. He himself sat down and think, after spending money on all these specialists, he sat down and think about it and said, what could be the cause? Now that they have helped him to eliminate all the so-called sophisticated causes, he himself started thinking of the simpler cause. Then he realized, for the last 6 months, he have not been sleeping his so-called 8 hours that everybody is telling you should sleep 8 hours. So he said maybe it's because not enough sleep, 5 or 6 hours. So what he did was, he just put it, after all it's your life, you can test it, right? No harm. So you know what he did? He said, okay, from now onward, I'm going to sleep at 10. Because initially he said, very difficult to sleep at 10 when he's used to sleeping at midnight. But after a few weeks, he did. Slept at 10 plus, woke up at 6 plus, get his 7-8 hours, dizziness gone. The dizziness gone. So he realized that actually, he himself, looking at it from a simple, I'm not dismissing a sophisticated, more complex phenomenon. It is there still, but at least as a first aider, you can do that first instead of spending money and eliminating all the negative part.
I can add something.
Now I got everybody excited.
I think we're getting somewhere because when you do health coaching, another aspect is what is your mental model about health coaching. And of course, it's very easy to be behavioristic. So you say, I want to change behaviors. I want to move people into better behavior. That's just one. But actually, what you are proposing is more network model, which is we are all part of a network and we are maybe good at something. Maybe if it's a quite serious disease, then the healthcare system is optimized for it. But for well-being, so actually once you start to think about as a network model, then you behave quite differently. Then you are responsible. You can ask your husband or your wife or your kid. You don't have to think every time I feel sick, then healthcare system is the first option. You just try to get rid of maybe I'm not having a good day, and actually having this network model, we can distribute the loads. Otherwise, we end up with this model where everything happens when a physician ticks the first box. You can imagine it's a very critical system because you cannot. The idea is not to have millions of physicians. Physicians have a purpose. So nurses, I think you have a good point, even from a research perspective. The mindset of how you build a system will have an influence of if you feel like you own your well-being is yours, it's not someone else to fix it for you. as opposed to someone, you have to go to someone to tell you that you are well.
Yeah. So then again, on this network system, which is what we are trying to create, it's actually a very important concept. Why? Because if I'm part of a network, if I feel out, I mean, it's very normal. In fact, most of us in any kind of, we were like, a lot of us are in WhatsApp group and so on. What do? If I feel a bit off, I just put it down. See someone else may have a similar problem, and just say, hey, I also had this. My way of dealing with this was this way. Then you try it out. So the part about being part of a network is, first you get these extra sources. Actually, the other part is we can encourage one another. That's important. That's why for us, when we were thinking of this whole health coaching thing, we're actually thinking from two possible perspectives. One was helping the group. Once you have that health coaching training, you can help the people in the group. Secondly, by being part of the group, you can encourage each other in the group. And I think, again, I was saying that point, in Singapore, our maturity in this is actually not as great as in other countries. Why? Because we always wait until the problem occurs, then we set up the group. That's our system. Got problem, set up the committee to solve it. Alright? So, actually, the better solution is to be part of the whole group that's already there, and it's a very natural solution. And this so-called, what I call interest group, is actually a better way of solving things. If we're already part of an interest group, the interest group can be in anything. I mean, hiking, okay, gardening, okay, or anything. But being part of an interest group, it means that within your group, you can help share any problems that you may have that, again, relate to elderly care in that sense. Okay, so you can see how we are looking at it from all these different perspectives when we talk about health coaching. Okay, any other questions? Someone there? Yes. Yeah.
Hi. It's really enlightening listening to the different views from the agency of the individual, as you say, and then to the community, and also then to in the sense of the policymakers, the government. Because personally, I'm a community health worker. I actually work in the community. So there are several factors that I'd like to share with you. First, talking about individual agency. Because before that, I want to bring it back in terms of the policymaker, the urban planners. Because I work with elderly who, due to our, which is a good thing, but also the other cutting edge of the sword is that this constant urban renewal, I have a lot of elderly who are displaced. The neighborhood coffee shop disappeared. Whole estate disappeared. And these elderly are relocated to various places in Singapore, and then they hide in their homes because they are no longer in a familiar environment. So although we want to talk about the individual agency, sometimes as a community health worker, what am I going to do? So how much do our agencies at the URA level, the HDB level, are they aware of the psychosocial emotional impact on the elderly when they redevelop these estates? And I can see blocks of flats that are left years empty, and they say, oh, there's some renewal going on, or some planning going on, but nothing has been done. In the meantime, these residents are spread all over Singapore. That's one. So although we talk about mindset change of the individual and even the community, I wonder how much mindset change, just how you were illustrating so many figures which, sessions and sessions that I've attended, talking about aging Singapore. But do our policymakers have this in mind when they talk about aging Singapore, that they plan with this population in mind in terms of urban planning, community planning? That's one. The other one, talking about doctors and nurses, because I really come from the community, so I face these issues on the ground. I have a client who lives in, previously in the east. So his record is in Changi General Hospital. Then he moved to the central, and he wanted to transfer his record from Changi to Tan Tock Seng. No, cannot. You cannot transfer. So he has to go to Changi General Hospital for his regular visits. So what I'm saying is that I'm not sort of blaming anyone, but I'm just saying that when we talk about mindset change about aging population and having the individual agency, community health worker agency, what about in the people who are making the decisions, the policy makers? Do they think about the psychosocial, social, emotional impact of the elderly? How much do they understand the psychology of the elderly? Thank you.
Maybe we hear the second question. Let's see where we go.
Yeah, good afternoon, everyone. I'm a retiree. What I want to share with you is, like Dr. Ao from Kong Wai Siu said, I'm a retiree taking care of elderly, taking care of elderly. My mom suffered a stroke, I think around 90. I think maybe she died about 90, almost 95. So I have to take care of her about 5 years, bedridden. So I want to share the thing that the problem that I face. You're talking about urbanizing healthcare. I agree. First, I did not want to put my mom in the home. I think Kong Wai Siu did a good job. I put her, an elderly home. I put her at home. So I did not choose to be a health coaching, but it just came to me suddenly. So I have to learn everything, like hospital bed. We have to get a maid, train a maid. It's good that the hospital, I think St. Luke Hospital trained a maid for us to take care. What I face the most is the bed sore. I think a couple of years, the bed sore just didn't heal. I think some of you I hit the right spot. That Singapore is a hot and humid country. Although we use air mattresses, cooling mattresses, turn the patient here every 2 hours, bed sore still there. And we have to change the dressing every day. We ask the nurse come. The nurse, they only just make sure make sure the bed sore will not get faster, which we can all do, you see. But how to heal a bed sore? Nobody knows. Ask a doctor to come. Most doctor doesn't want to do home visit. Those who come to do home visit charge a very high price. No problem, come. No solution. So I would appreciate if there's more research done in how to make cooling bed, how to prevent bed sore, how to make bed sore heal. This is my question. Thank you.
I think the bed sore is the latest one is the water bed. It moves by itself. Even for nursing home, the theory we always have is 2 to 4. If you have a good mattress, you can cut from 4 to 2. That means the turning. But more recently, they're also looking at the nutritional status of the elderly and in terms of skin care. So there are many facets to it. So looking after elderly at home under such situation, yes, it's very tough. But there are measures that can really do quite well. In fact, there are some home care physicians who are looking at a little bit higher protein element to help this elderly. Some of the elderly may be on NG tube. They increase the protein content. But you still need to do the basic garden thing. Sorry, use the word garden. The 2 hour, 4 hourly, depending on what bed you have. And then looking at the posture, you have to add certain cushioning. The simplest cushioning is a glove, you blow it up, or a balloon. It doesn't really matter. But you still have the basic. But now they're looking in terms of nutrition. And but once the wound starts, really it's a very difficult thing. Because if the nutrition, the status of the elderly don't come in, there's actually very little money, because you only want to hope is don't have infection. Once the infection, the condition deteriorates, you go to the hospital. So the prevention part is very important. That means day one after going home, you must do all this already. Once the wound come in, once it's a bit dry, it forever be there. Of course, conditions like when the patients have diabetes, very blood poor supply, no matter what you do, it's a bit difficult. But I think that one, I really think that this is a solution whereby the home care providers can only do up to a certain amount, but there are definitely certain things we can explore. But in terms of the policy one, I guess I have to take that because I always consider myself as a public servant. And I have been a public servant in healthcare. I was also in Ministry of MTI. I was also with Dr. Toh in MCDS, and I take care of finance. The answer from UIA, they definitely will tell you yes, they definitely consider. So every new estate, in fact recently my engagement at HDB was very interesting. They came to a certain conclusion based on their finding is that actually it's not good to have a retirement village style concept. They prefer to have an estate that have everything, young and old, and then mix it up. So whatever it is, they have come to a certain conclusion. And so they started to say that they will do that. But my comment is that nothing wrong with that theory, but I'm saying existing historical memorial area is actually easier for elderly to get used to. Don't overdo it like what you say. Or why don't you build on it? Rather than go and create something, for example, so they're trying to create this Disneyland in the north, the Admiralty, but they don't call it retirement village, they try to do it. But for an elderly who is very unfamiliar with the area, something new, they may not want to go there. Right? But whereas for me in Kong, as you around us, it's 100-year-old sites. They build something there, they don't want to call it retirement village, they don't want to do that. So I think to be fair to you, the current model is that they rather have this multi-generation. You have kindergarten ahead, but then in the midst of it, you have some of these elderly. But whatever it is, you're absolutely right. The look and feel is totally new. In fact, Kong, as you have been taking, we are the first so-called to tender, we got this active aging hub in St. George area, which is near Wangpo. It's actually like a condominium estate, all new. But right smack in the media is a clubhouse. We are going to run that clubhouse. But they refuse to call this as an elderly place because they say that's a bad taboo. So we are going to anticipate a mixture, but they put the clubhouse in the middle. So to answer your comment, then this is what we need to do. So for us, when we are doing these care services, we no longer look at just those who are frail and who need rehab. We also take care of the wellness part. So when we take care of the wellness part, we start to tell ourselves, don't make the place look like a septic polyclinic look-alike. It must look like your care. So for the McNair one we have opened, we have this community care concept. We put the oldest teak wood down there, which is from Gongwasi. We dismantle it, put it there. Since World War II, put there. We get SIT students to design the place. Then in the St. George, the new one, we decided to make it in a sports and recreational look like. So those members can then move on both sides. I think that's all we can do as providers. But I think for UIA, I think the direction is still that they right to have a mixed one. They are very concerned about this taboo. In the private sector, you realize recently somewhere in Jurong area, they have this retirement condo. That is the marketing. But after the sales, you realize hardly any elderly because they just sell whoever wants to buy it. So then because of that, the MCST or MSCT start to change. No longer you have the elderly flavor or the things. So the marketing campaign is just a smoke. At the end, the developers sell the unit, they don't care already. But when they started, they call it, and it was supposed to be a short-term lease. Yes. So I don't know who called who, whether they called the government or the government called them, but it doesn't matter, the development earn the money and they run away. Those people who buy it at 60, not too bad at a certain level, it's a condo, but the essence of original marketing has totally flopped. It's no longer real, because those people are talking, but fine, for the youngsters, they're fine, they're happy with it. But that's a reality. I mean, Singapore, no choice. That's scarce. These are my thoughts.
To add on, like from the research, like community, we have been engaging with, like for example, like URA, JTC, and so on. To be fair, I think, like they are beginning to understand the issues. Like so, like the recent MOH. Like focus is actually not a retirement village. So I have actually been going to, like senior activity centers where they put up, like elderly in, like HDB blocks and so on, it's not working. Like, so when it comes to, like if you're someone who has passed on and the unit is actually vacant, they actually bring in, like families so that they actually mix them around. So currently the MOH policy is really looking at city for all ages, and that's where the concept is. So these are some of the, like kind of, let's say, concepts, but we still need to have it tested to see whether it works out or not. As far as I know, there has been a project that has been funded in Nampo, and looking at livability. Like in the older estates to see that, like what are some of the amenities and the facilities they are trying out. And when it comes to, personalized healthcare records, like just a couple of weeks ago, right, they talk about harmonizing all the data records. And, so the government and the ministries, they are working towards it. Solutions may not come overnight. And that's why they also engage with universities to look at, solutions like, bed sores, like we have the Skin Research Institute. They're looking into some of these research areas and working with community. But it is, like we are not, actually, like we are not that far away, because I think Singapore is really well positioned for us to actually introduce technologies and see how things can actually work out. But I think, like comments like this would be very, very useful for policymakers, for researchers, so that we understand, like the real issues on the ground and begin to actually look at, like solutions, breakthroughs that will be really relevant for the community.
Yeah, I hope all of you have benefited from the discussion so far. But for us, we have gained quite a fair bit. So it's actually very, very good for us in terms of what we can look at in terms of our training, not just for health coaches, but also into helping people into palliative care, as well as hopefully those who are involved in policy making and so on. Thank you very much. So if you have more questions, feel free after this just to talk to him.
Yeah, the panelists will be hanging around, so you can actually ask them questions.
I thought 10 o'clock I started to sleep.
Oh, okay. Before we go, I'd like to invite Prof. Theng to help us present a small token of appreciation to our panelists. And let me also announce that in order to show their good gesture, the caterer has asked us to pass a voucher to you because the food was late. So on the way out, our helper will actually pass you one voucher each. Okay? Thank you. And please come again. As I've mentioned, we are doing this on a monthly basis. So we try to announce it as early as possible, and then we hope they can come again. For those who are taking our buses, I think go to the same place at the Heritage Center. Buses are there, and then we can go from there.